Hello, YouTube. I wanted to get on here and answer a specific question that Thierry Morin in Canada asked the channel. I would very much like to listen to what you have to say on trigeminal neuralgia because I am one of the TN zombies. Please do post on this channel. I live in Canada and my dentist has never heard of TN, nor did he seem very interested in hearing about it. Yeah, so this is pretty common, especially among all of the chronic orofacial pain diagnoses, if you will. TN is just one. And so dentists generally don't get a great education in orofacial pain. And irregardless of whether you're in the US or Canada, it's just not something that a lot of time is spent on. I think our orofacial pain course was one semester, sophomore year, and it might have been maybe 2 or 3 credits. It wasn't worth very much. The same with occlusion. And so the occlusion that most of us get in dental school is freshman year. It's paired up with dental anatomy. And again, that's only worth 1 credit. So none of the stuff that you're going to be hearing on this episode is really taught in dental school, although the principles are valid and every single school teaches to those principles. They just don't measure, okay? Okay, so how did I come to be somebody who treats TN in my practice? And so I'm gonna go ahead and tell that story. Sometime about 18 years ago, 19 years ago, early on in my practice, I was treating a lot of motor vehicle accidents, working with some personal injury lawyers. And I was building a lot of neuromuscular orthotics at the time. So this is where you tend, you find the myobite, and you build an appliance to that position. Probably done maybe 75, 100 cases. And at the end of one of these cases, one of the patients, female patient, said to me, well, Dr. Sutter, you know, this worked really, really well and took care of all my motor vehicle whiplash type stuff. And I really wasn't expecting it to take care of my trigeminal neuralgia. And okay, well, you hear that the first time and you're like, you know, patient's crazy. She doesn't know what she's talking about. And I fell into a trap that probably a lot of doctors, MDs, dentists, regardless, fall into. And so I just said, okay, well, that's great. I'm glad you're doing better. And, you know, on to the next thing. So about 2 or 3 months later, I had a second patient who said, you know, I'm using this thing and all my trigeminal neuralgia symptoms are gone. Like I haven't had that in months. Do you think that this is related to that? And so now as a practitioner, you have to take a step back and be like, okay, like I've heard this twice now. Patients aren't crazy and the doctor has to start paying attention, has to start listening. And so from that point on, I was doing I really wasn't writing at the time, but I was doing some local presentations to the dental society and letting other docs in my area know that this was available. This was a resource, and hoping to get more like patients so I could learn more and hopefully help some more people. So what happens is over a course of, you know, years, you get familiar with what it is and what it isn't, right? And so let's pause there and let's go over what is trigeminal neuralgia. Because what I learned in dental school is it is some demyelination of the nerve sheath. And so you have contact with the trigeminal nerve at some aspect. It could be a tumor, neurovascular compression of the trigeminal nerve root. And when we go to something like Burkett's oral medicine, which is a textbook most dental schools use, especially not the oral facial pain, but the oral medicine department of many dental schools, that's kind of like their Bible. And so that book or that reference says that, you know, a tumor or some neurovascular compression only accounts for 10% of the cases that come through. And so that made me think, because that means like 90% are idiopathic, which is a fancy word for we don't know, okay? But that's a big number to sweep under the rug. So we're missing something, right? And so fast forward a little bit, and we get to my first patient that I did DTR on, which stands for disclusion time reduction. And she comes in, she's been diagnosed with trigeminal neuralgia. And so she and I are talking during the consult, and I hook her up to the biometrics, the T-scan, the bio-EMGs, and we're looking at her data. And she's like, well, I don't want you to build me a neuromuscular orthotic. I want you to do the bite adjustment thing. And I had never done that for such a diagnosis. And so full disclosure, she knows the risk, and she's like, I want to do it anyway. And so that's actually Lori, and her video, I'll put a link down in the description for you to click on. You can watch her. And so the interesting thing is, while I'm doing this case, you're seeing her face change over time as she's feeling better and the chronic pain is going away. She actually becomes more of her old self, more talkative, more funny, more engaging, and more emotional. Not emotional upset, but emoting more, not having a flat effect like so many pain patients do. Like, you're afraid to smile, you're afraid to laugh if you have trigeminal neuralgia, out of what could possibly happen if you do that, right? So what happens is I go ahead and I have a good case with Lori. She's still in the practice. You may have even seen her follow-up or some other videos that she's done for the office. And once it's posted, what happens is the office starts getting phone calls from all over. Most of them are in the Seattle, Portland area, Oregon, but I get a couple that, travel from out of state. And as I'm doing more of these cases, I start posting more of the videos. And so people are calling now from all over the world and traveling to have this therapy done because they can't get it done in their country or their state. No one's close to them. Okay, so we move a little farther down the line, right? I've been doing this for a few years. And all of a sudden, when you're using biometrics, you have the opportunity to compare one patient to the next, right? Almost akin to taking blood pressures, and then all of a sudden you notice that elevated blood pressures all of a sudden have a higher incidence of stroke and heart attack. And, your lower BPs, 120 over 80 or in the middle range, they don't have any of those problems or greatly reduced onset, right? So TN works the same way. I start to write a paper, or I do a book chapter actually, about one case. That happened first. And so I have to go and read, when you're presenting a case, you have to do what's called a lit review, where you basically go into Medline and you do a lot of searches on things that are relevant to your case or very similar or might correlate. And so you do a lot of reading. And one thing you find out is that, the discovery of what TN is happened in a cadaver study. And it was a surgeon that was practicing on cadavers. And he saw these dents in the nerve tissue of the trigeminal nerve. And so the hypothesis was, I wonder if this is related to trigeminal neuralgia. And it's not a bad hypothesis, right? So, you start with that and you start doing a correlation among people that, and at the time, let's back up. At the time, there was no MRI when this cadaver study was being done, okay? And somebody else came along by the name of Dandy. Hopefully I'll have some of these citations for you down at the bottom of the screen, and you guys can just go look them up, okay? Do your own research, which I know so many of us have to be our own advocates in medicine and or dentistry these days, but I'm gonna put these references for you to go and look up. Dandy found like a 50% correlation. That's not good, okay? It should be 85, 90% correlation before we start working on people's brains. So I'm reading this. I'm reading this for the first time, and I'm like, this would not hold water in today's scientific literature. It doesn't meet really a good criteria, percentage-wise. And so the reality is we just don't have anything better. And so everybody gets lumped in. And where I struggle as a practitioner is 100% of the people diagnosed with trigeminal neuralgia all of a sudden get treated the same. But wait a minute, only 10% have the neurovascular compression or the tumor. So what are the 90% being treated with? The exact same thing. But wait a minute, remember that's idiopathic. We don't know what that is, but we're treating people all the same. All right, so at this point you might be saying, yeah, Dr. Ben, but there's MRI. And the MRI will show a neurovascular compression on the right or the left side. And so let's unmask that just a little bit. You know, there have been 3 studies that have been done using MRI. And what was done was they took people who had trigeminal neuralgia, diagnosed with, and then they took a second group, and those were the control groups. So people with pain, people without pain, and everybody got an MRI, okay? And what happens is they have some interesting findings. There are people that don't have pain that have a neurovascular compression. You're like, well, There are people that are diagnosed with trigeminal neuralgia that don't have any neurovascular compression. And so you're like, well, that's crazy. How can that be, right? I mean, it's an MRI, for goodness sake. Well, and we have to understand too that an MRI has to be evaluated and it has to be interpreted, okay? And that's subjective from clinician to clinician. And so there was a study, you know, back in the, I think Reader's Digest did this like in the 70s or early 80s, where they took a full set of x-rays and they showed it to a dentist and said, well, what needs to be done? And it was everything from don't do anything to full mouth reconstruction, depending on what the dentist saw, okay? MRIs, strangely enough, behave exactly the same way. And so a study was done a few years ago where they had a patient who had lower back pain. And this patient had surgery, the pain was addressed. And then they sent the patient to 10 different MRI clinics to be evaluated to see what would be found. And within a 2-week period, this patient had 10 MRIs, and the researchers collected all the findings, and they found over 40 different findings. No 2 were the same, right? And the pain was removed for this patient. So when a big portion of our diagnosis is based on an MRI finding, you almost have to take that with a grain of salt. So those 3 studies were done in the 90s by 3 different sets of researchers, and the MRI study was done only a few years ago. And I'll post the reference or the citation for that, and you guys can go and look it up on your free time. And maybe in a few weeks or next month, I'll put out a video on my story for Meniere's disease and how I became a person who treats that, even though ENTs don't believe that has what I do has anything to do with inner ear issues. Hope that helps, gives you some hope, maybe gives you something else to think about if you've tried a couple of these things. If you like the channel, if you like the content, please hit subscribe, give me a like. That helps the channel create some of this content that is very effective in helping a lot of people. One last little comment. I'm going to put a link to a case presentation that I did when I was in Canada. It is a PowerPoint presentation. I'm presenting to a large group of docs, and it may reinforce some of these concepts. Okay, thanks.